in medicine and what we know, where we are, and where we need to go in terms of these issues.
Thank you. Our next speaker is Dr. Tracy Montessa. Her pronouns are she, her.
Hi, everyone. My name is Tracy Montessa. I am one of the advanced practice nurses here at Advocate Illinois Masonic Medical Center. I oversee the telemed search department as their clinical nurse specialist. As an advanced practice provider, I oversee a lot of system rollouts, supporting education in the nursing department, and then providing consultation at the bedside. So I'm excited to give you guys a little bit of a macro system point of view while the physicians give you more of a clinical point of view.
Thank you. Our next speaker is Dr. Danny Rodgers. Her pronouns are she, her, hers. I'm not sure if Dr. Danny Rodgers is currently in the meeting, but I can go ahead and introduce her for her. So Dr. Rodgers is a native to Chicago, Illinois. She completed her medical training at the University of Illinois College of Medicine at the Chicago campus. She went on to complete her obstetrics and gynecology residency as chief resident and maternal fetal medicine fellowship at the University of Illinois at Chicago Medical Center. And she will be joining us shortly as well. And our last panelist speaker is Dr. Sarah Aboud. She is our mentor in the program, and her pronouns are she, her. Okay, and so to begin with the event, I'll start by posing some questions to the panel speakers who can answer it and add on. Speakers are encouraged to interact with each other and ask follow-up questions. We, the hosts, will monitor the chat and pose additional questions from the audience. So audience, feel free, if you have any questions, type it in the chat box so we can bring it up. And I'll start with our first question. For attendees who may be new to this topic, can you briefly talk about examples of racial bias in the healthcare industry? Dr. Robinson or Dr. Tracy Montessa can go ahead and answer that.
I think, Tracy, are you
That's
about
okay,
to
you can go ahead.
I mean, I think actually, Temi, you touched on a lot of important themes, and I think honestly this year we're focusing a lens more on how integrated it is into teaching and what we learn in our training. So I think it's a broad question, but some examples, like even within dermatology, are when we're learning about skin disorders, skin diseases, and just how to diagnose it. Ingrained in the definition of that is the color red, and we can't, you know, on deeper skin tones, we don't always appreciate red as a pigment. So that in and of itself, that definition can lead to either, you know, misdiagnosis or definitely downgrade in the severity of the condition.
And then just to add on to that, what we do occasionally see sometimes is that providers are unaware of their unconscious racial biases. So when they do go and consult their patients of different races, they may say that this patient is more likely to be compliant than this patient just based on their own personal unconscious racial biases. And that does go into effect with the care that they receive in the hospital, not only in the hospital, but the consults they receive to go home, the support that they get while they're at home, and how we set them up for success.
Thank you for that. So another question, I guess, that I have related to that is, what is the importance of patient-centered care?
So your patient is the consumer. They have purchased this whole package of coming into this institution that's going to deliver care, right? Patient-centered care means that you are taking into account their personal feelings about how they want to drive their care and respect that. For example, I like at the beginning how you address our pronouns. That is something at Advocate Illinois Masonic that we really pride ourselves on, is making sure that we identify, or we let the patients identify how they would like to be identified throughout their stay to make them most comfortable, and also so that the provider has a better understanding of how to take care of that patient throughout their stay. There are certain things that patients want throughout their treatment that might be different than any other patient coming in at that time. So really listening to that patient's concerns and requests and accommodating your treatment plan to really make them feel heard will give you the best return on investment, because that patient is going to start to feel that you're listening to them, they feel supported, they'll come back for their next visit. And you want to start building a positive rapport with your patients, right? If you don't listen to your patient, then you're doing a disservice not only to them, but to yourself as a provider.
Tracy, I appreciate that response, because I think that, like from a physician standpoint in medical school and in training, we don't learn a lot about the business of medicine. And I mean, actually, we don't learn anything about it. And I think it's important to understand that, like, historically, medicine, it was a, kind of a paternalistic relationship with the patient. We were telling patients, what they should do, and we weren't like really seeing the patient, and I think that now the demand on both sides, from providers and from patients, is to have like more of a relationship, and it's more of a conversation. And definitely in my practice, sometimes patients are like, oh no, you're giving me too many options. Can you just choose for me? And I'm like, well, I need you to understand and make an educated choice. And so I view my role as kind of educating the patient on the treatment options and letting them have like more onus in their care. And I think that when we're talking about the issues of systemic racism and implicit bias within medicine, we have to talk about viewing the patient in their whole self. So that means being culturally competent. That means the list goes on, right? That means actually taking into account the personal factors that influence that patient's life and involving that into your care decisions.
Right, and I definitely agree. As a provider, you can talk until you're blue in the mouth, but if it doesn't fit into that patient's lifestyle, if it doesn't fit into how that patient wants to live their life, whatever recommendations that you throw at them from your perspective is not going to be beneficial to their long-term health care. They have to want it. So you have to be very cognizant about the language that you use when you're offering choices to them. And I love how, Dr. Robinson, you said that you really put an emphasis on educating them about what is available and having the patient have that conversation with you about what is possible for them. So thank you for that.
Thank you, Dr. Robinson and Dr. Montesa, for that. So another question that I do have is, what does patient-centered care look like for patients that are coming from an underrepresented background or underrepresented communities? And how do you feel like your education, your training has prepared you to care for communities and environments such as that?
I don't want to keep talking too much, so you'll tell me if I am. But when we're talking about caring for patients from underrepresented communities, there's a term that's sometimes thrown around called like a medical desert, or in dermatology we call it like a dermatology desert, which are areas typically in an urban environment, areas that don't have a major hospital, or all of the clinics and things that we would see in other neighborhoods. They have to travel a greater distance. There's probably some other things there, like food deserts are also in similar locations. So we're typically talking about Black and Brown communities. And when you're talking about caring for patients in those underserved, kind of locations, then there's a lot of history that you have to take into account. And in that history is a bit of a distrust for the field of medicine. So I'm always, cognizant of that when I'm talking about treatment options. There's things that patients are like, especially in my line of work, that patients are like, no, automatically, like needles. I don't know. We need to do some research on that. Needles, are they're like, no, I don't want, like, has this been researched? We have to have a conversation about it, because there's a little bit of lack of trust that still exists with Black and Brown communities and medicine, the whole field of medicine. So I think that's one thing when we're talking about caring for underserved communities. But another thing is just what we touched on, is making, helping them make decisions that are going to work with their life. And for example, approximately half of my practice is hair loss. And when you're talking to a patient with curly, like tightly coiled hair that washes their hair every week, if I was to just prescribe what is in the textbook of like ketoconazole shampoo daily, some patients would do it, and then the result is dryness, breakage, and more hair loss. So I have to think about what's going on, like what fits in their lifestyle, and I have to think about meeting them where they are and finding a treatment protocol that's going to work for their lives, basically.
I'd also add, especially in these underrepresented communities, patient-centered care, from my experience, is also being cognizant and respectful of their socioeconomic status. If you are going to be prescribing medications that are not covered under the type of insurance that they have, or if they don't have insurance at all, those are things that you really need to take into consider when you are doing your prescribing and when you discharge these patients. Because if you don't set them up for success, they're not going to take the medications that they need or that you have decided on, and decided on together, of course, having that patient-centered conversation, right? They won't have the resources to purchase those medications. We're talking especially about the diabetes population here. So of course, if you look at the underrepresented communities, and if you have a very socially economic community that is a low socioeconomic community that looks into taking a lot of fast food, that plays into their diet, and diabetes medications are not cheap. So the sustainability of that treatment plan, it does affect what their care is going to look like. And then I know we touched a little bit also about their resources as far as transportation. Dr. Robinson mentioned before, if you're going to be setting these patients up for consultations or various doctor's appointments at different clinics to get the help that they need, are they going to be able to get there? What does their child care look like? If they're a single parent at home, who is going to be watching this kid, especially in these times with the pandemic going on, where childcare is pretty limited. And if you're living in an underrepresented community with low resources, that really tightens your opportunities a lot to receive really good health care. So those are some things to take into consideration.
Thank you for that. So it seems that like as a healthcare professional, your duties don't just involve like direct clinical care. You also have to take into consideration the whole aspect of a patient's life. So how do you feel your education has like prepared you to look at the bigger picture when you want to treat a patient?
So I've been trained as an advanced practice nurse. We really take a look at our training in a holistic approach, making sure that we understand all important aspects of the patient's life as we go to assess the patient. So I think that the training in the advanced practice world has been good so far. Of course, there's always room for improvement, right, with any program. And I think conversations like this are essential, especially amongst students. So you can start thinking about these things early, and then throughout your didactic course and your clinical, you can start implementing what you've learned from panels like these.
I think also sometimes it's just as simple as like thinking about yourself on the other side, like literally putting yourself in the shoes of the patient. And that should be the expectation, like, or thinking about one of your family members, like how would I want my dad cared for, or how would I want my mom cared for, is really helpful when you're starting to think about, those things.
Thank you. So I believe Dr. Rodgers has joined the chat. Dr. Roberts, Rodgers, sorry. Do you mind introducing yourself?
Yeah, no problem. Sorry about the delay. I was having some internet technical difficulties, but I am Danny Rodgers, and I am, oh my God, I work as a maternal fetal medicine specialist, basically high risk OB. And I trained at UIC, so I'm born and raised actually right in the UIC area. So this is really true and dear to my heart to be able to participate in something like this, but I'm actually from your area. I am the director of maternal fetal medicine out in Rockford, where we serve as the Northwest Perinatal Center. So I basically take care of the upper part of Northern Illinois. Kind of filters into our hospital in terms of maternal care and fetal care. So, that's my specialty. In terms of my interest in the particular topic that you're speaking about today, is that we have a huge interest in it because I'm sure, as you all know, and have your kind of fingers on the pulse, is that maternal mortality in particular is very, very high amongst the non-Caucasian population, right? So the morbidity and mortality of somebody actually walking into the hospital that's pregnant, 1 out of 8 of those people won't make it home. And so it is something that is lately has been publicized a lot, and just kind of looking at it. So I have a special interest in that, just trying to make sure that we look at things to try to attempt to figure out why it's so different when we compare ourselves to our non-minority counterparts. But thank you. I'm glad to be here today.
Thank you. And I'd like to finally introduce our last speaker, Dr. Sarah Aboud. Do you mind introducing yourself as well?
Hi, good afternoon, everyone. I am Sarah Aboud. I'm an assistant professor at UIC at the College of Nursing, and I'm the faculty advisor of Women's Health Initiative, the organization that has organized this amazing panel. So thank you. My work is related to sexual health promotion, specifically among immigrant youth. I work specifically with Arabs and Arab American immigrants here in Chicago, looking at sexual health promotion and sexual violence prevention. And I appreciate this topic a lot because being part of the College of Nursing and the educational system of the healthcare also is eye-opening in so many different ways about how we lack in being inclusive in our education, whether it's nursing or medicine or any other healthcare profession. So these conversations are important for us to also be critical of the way we teach our future healthcare providers and what we are still missing from the perspectives of a lot of vulnerable and marginalized populations. So our textbooks are very white focused, and so there's a lot to be done. And as part of also of our diversity and equity committee, being involved in like the curriculum committees and how we teach what we teach for nurses is really like taking very slow steps in changing that. But again, like these panels really help us keep the conversations happening. So thank you.
Thank you. So far, we've touched on the importance of patient-centered care. So a question that I pose to all of the panelists is, what are some ways that as physicians, as healthcare providers, how can you advocate for your patients in a clinical setting and then maybe outside of clinical settings?
So I would say, first of all, of course, I agree with the responses that we have been able to come up with so far as a panel. So I definitely agree with that and echo the prior sentiment of the last doctor. In terms of how you can advocate for your patients, I think that, or at least for me, and my area is a little bit different than other areas in that the other areas you typically will see patients for a length of time, right? So it's a patient that is maybe established care, so you may have a longer history with them going forward in terms of their medical history. Whereas in obstetrics, as you know, because we really are just involved in a time point. So my interaction is a little bit shorter. So I only get that 10 months, right? If 10 months is kind of stretching it, but about 10 months where you will interact with the patient or become a part of their lives. So for us, things are probably a little, the pacing may just be different. Some of the ways that we advocate for our patients, of course, is number one is just to make sure that they understand like what is going on, and we make sure that we explain it in a way that they can understand it. So one of the methods that, of course, that we've instituted is teach back. So if there's something happening or there's something going on, after we've explained it the best way we can as providers, right, then we ask them in their words to teach it back to us, right? Or what are you going to tell somebody else when you leave today, so that way that you can make sure that they understood what it was that you were trying to convey to them, okay? And how does that relate to being important to their healthcare? So that's one of the ways. The other thing, of course, is just to try to make sure that we identify any social barriers that could stop them from getting the optimal care that we think that, you know, would be beneficial for them. And so sometimes that could be just as little as, do you have access to get prenatal vitamins? Do you have access to get to the clinic? Do you have access to get prenatal labs? Do you understand why those are important? You know, things like that, just seeing what support they have. And if there is something that's available, then being able to kind of couple that with the patient that has that need. And then, of course, we take another step forward as we start to kind of plan in terms of when we are getting ready for the patient to deliver. So what is that picture going to look like? Who is the person that's going to be the primary responsible person? What pediatrician have you picked out? Do you have a pediatrician? Have we started to kind of think about like what things are going to impact that new family in terms of maternal care going forward and in terms of neonatal care, right? Because we do know that there are the statistics don't look good either way. So whether that be the statistic of looking at a Black mom in terms of maternal morbidity, or a newborn, right, in terms of being a Black baby or a minority baby, those statistics just aren't good. So now we're trying to take it a step further to make sure that we have that follow-up that they need early. We start those conversations early. If there's any centering programs in the area, meaning that, you know, it's like when, if you haven't heard of centering, so it's basically where pre-COVID, you would have different mothers kind of come together that are similar in terms of their gestational ages, and just kind of have like a group. It's almost like a group prenatal visit. So they get the opportunity to kind of talk about what things are affecting them, impacting them, and share that with others. And then hopefully that conversation, right, or that space that you create will make it more comfortable for them to be willing to share with you. So those are the things that we do on the healthcare side. And you also mentioned advocacy outside of the hospital. So I think this is where things are very important, and that there's been a lot more, I'd say, movement. And this is where you guys get involved, right? Because I think that what we are now learning, and what you're seeing, right, when you look across society, we have to be involved, right? And so you have to be more involved than just those four walls of a hospital, just because those things that are outside of the hospital actually impact what we can do in the hospital, right? So the things that you vote on, the things that you advocate for, the things that you protest about, right, those will impact the social programs that are available. So if I do have a patient where I identify that there are some barriers, right, the goal is to be able to then connect them with that resource. There's nothing worse and nothing more disheartening for me as a provider to identify barriers and not have a resource. And so that advocacy that needs to happen outside of those four walls is so important. And I think that now we're kind of starting to get more traction in terms of people understanding that what you do and what you vote for and what you stand for outside of the hospital truly impacts what we can do in terms of moving forward to try to reduce maternal morbidity, right? Reduce neonatal morbidity and mortality. Those dollars that are divided between us, right? You make that difference. So I'd say, as being outside of the hospital, the things that, you know, we are involved in, and of course to each his own, but we are involved in are things like, you know, educating people about what the problems are, volunteering to be parts of community committees and community panels. So that way patients understand and the community understands, right? Volunteering at fairs. If there's any fairs that comes up and they need a physician or obstetrician to go speak, I'm more than happy to do that and be willing to just kind of give that additional time outside of the four walls. But those are the two ways in terms of advocacy that we have tried to step up to do. There are other things that also go on too, but I would say those would be the main things.
I echo all of that, because it's so important, especially what you said, that the advocacy work that's done, sorry, Dr. Rodgers, I think we're just now, the advocacy work that is done outside of the hospital is just as important as what is done inside, you know, or outside the clinic and inside. And so I always, you know, talk about kind of a couple of different buckets of advocacy that you can start to get into. And you're absolutely right that you can start to get into those buckets as a student. And as a student, one of the easiest ways to get started is just by inspiring other youth to even consider the field of medicine, because we have a diversity issue, like, across the board. And within the specialties, it's even worse. You know, in dermatology, less than 3% of physicians are Black. So we have work to do there. And that is one of the easiest ways. You know, when I talk to youth pre-med, it's, well, I don't know, I was told that I couldn't, or I don't know if I can. And just dispelling that myth can be so impactful for students that are even, you know, considering the field of medicine. So it's mentorship, it's sponsorship. We need to improve the representation in research studies. There's so many different arenas that we can start to advocate in, and it's going to take some time, but I think that we can do it.
I'm just going to chime in here. Not going to switch this into a political talk, but just vote. Be very, very cognizant about who you are putting in power, what they stand for, how is that going to impact the healthcare industry that you are earning your degree towards. Because, you know, those decisions are going to either create barriers for you in your practice and your patients, or they could help support your practice and what you're trying to achieve for your patients. So do your research. I know when I was a student, I wasn't so good about that because I was swamped with my schoolwork and all that stuff, and politics wasn't really on my radar. But once you're actually practicing and you see the impact that the politicians have on your practice, it's important to pay attention to. And I really want you guys to be aware and well-versed in your candidates.
I couldn't echo that sentiment more. And of course, I always feel like whenever this topic comes up, OB is one of those things that, you know, I mean, you can't turn on the TV without hearing somebody fight about something going on in somebody else's uterus. So OB obstetrics in particularly is kind of always up for grabs for every election. So, you know, I couldn't stress again how important it is to, you know, to pursue those things that the panelists like Dr. Robinson has mentioned and Dr. Montessa has mentioned. It is so important. And I think that even when I trained, I can't tell you that I was even into politics. I knew who was, you know, I knew kind of the general gist, but it really wasn't something that was on my radar. I just think that now things have changed so much in terms of access and social media and just politics becoming a part of medicine, where before it just used to not really be so much. But now that has changed. And so I think as times have changed, we have to change with it, right? In order to kind of really deal with the constructs of the landscape that we have. The reality is that we just, none of us no longer can afford to take a seat back, right? We all have to be involved in some way. I'm not saying that everybody needs to be out protesting if that's not what your thing is, but there are ways that your voice can be heard, and voting is the easiest, right? And you can do that in the confines of your own space. So, you know, just make sure you exercise your choice. If you ever have a choice, always exercise it.
Just to add also a little bit to what Dr. Robinson mentioned related to representation and the lack of diversity in not just medicine, but almost all healthcare professions. Same thing, nursing struggles with being a white women profession. So representation does not come easily, especially for students of color who do not see people representing them, whether as faculty teaching them or when they're going into the hospital settings for mentors and clinical instructors. So we really need to encourage more youth to join the healthcare professions in so many different ways, but not just by increasing diversity by numbers, but also ensuring that we have environments that are inclusive and supportive. So making sure that these students, again, like Dr. Rodgers was saying, if students are facing challenges like your patients, if I don't have the resources for them available on campus to support their academic success, a lot of students drop out, and most of the students who drop out from healthcare professions are students of color or students from different marginalized identities. So again, this is to reflect the diversity and inclusive environments within our campuses. Another thing that we need to also work on, I think, and we are in some ways changing the curriculum and how people are represented also in the curriculum that we teach. So our curriculum are mostly very heteronormative. They exclude a lot of like the LGBTQ identities and people of color. Pictures in the books don't represent people who are studying from these books. So all of these like make a change and have a big impact on the success of students if they do not see themselves represented in faculty, in books, and research. So that's what I see my role as an educator outside of the hospital, and also how to incorporate students learning to becoming more engaged in social justice initiatives outside of their work. So like others were saying, like while they were in school, they were not maybe a lot political, because we do not provide as educators the avenue for students to really see the link of their education with politics and what's happening in societies. And this summer, we've seen more and more students, like during the summer courses, speak up in the classroom, object to faculty using racist terminologies. Like we have seen how much the Black Lives Movement that has been going on this summer has impacted students within the classrooms as well. So this is all connected, and like definitely there's change, but it's slow, but it's happening.
Thank you. So for a lot of us students who are interested in pursuing careers in the healthcare field, a lot of our coursework right now, it's very science heavy, and we kind of tend to push back like other subjects or interests. So how do you as healthcare professionals, how can you advise us to engage in work that reflects anti-racism and just basically learn to diversify our interests?
So I will say that I don't know. I may have to just listen in and take notes on this part, because I think it's a fine line, right? And the reason is because although the sciences is heavy, or the sciences are heavy, it's important. Right. So in order to be able to be an effective advocate, and in order to be able to do all the other things that you're going to need your community to do, you have to be well educated though. So we don't want to miss that part, because that is super important. When the, and again, I trained a while ago. So when the, I think it's the RRC came in and they kind of started to change the amount of hours that you could even be present to learn. I think that, you know, kind of impacted what amount of the science portion or the bedside portion that, you know, you actually have as a student. So that part I definitely don't want to undermine. I think that one of the unique things about training in medicine in particular is that the thing that they don't necessarily tell you is that in med school, a majority of it is self-taught. It is adult learning. So the majority is no longer where you're sitting and somebody's feeding you information and you're taking notes and then you recite it for a test. So a lot of times when I have students that come from the clinical perspective, I'm already expecting that they've done the work that they need to do to participate. And so I would say then that expectation, and that's for the scientific component. That expectation, though, is no different when it comes to this type of issue. I just think we haven't made it as such a priority, right? So yes, that is still the expectation that you as an individual, even if it's not something that is strictly offered in your curriculum, I think that, you know, you being able to search out what is important in terms, and right now it's just so much information that is out there. You can simply Google disparities and a million things will come up. And so different ways for you to be able to kind of educate yourself. But I think that in this initial part, as the curriculums are starting to change and we're trying to move toward that direction, I think that the reality is that takes time. Right? Time that we really don't have when we're training the future. The future is now. So I think it is going to be incumbent upon us to do things just like you guys have took the initiative to arrange this. You're going to have to take control over that, because remember, the people that are in charge of your curriculum are people that even trained before me. And it's unfortunate to say, however, but the reality is that our training, the books that we use, the formats that we use, are all based in a different type of system, different than what we see today, right? So we're talking before where I'll just speak for obstetrics. Right now, we're probably about 90% women. It used to be 100% men. So when you look at our textbook and you look at some of the verbiage and you look at the things that were done, you can clearly see that they did not write those books and write those curriculums with today in mind, right? But nonetheless, we still study from them because that's what we have, right? We still know some of the things do carry over and do carry on. So, you know, I just don't think that's going to change as rapidly as we need it to do, meaning today. So at this point, it's going to be incumbent upon you to try to, you know, do things again like you've arranged today. Participate, get to know as much as you can. And when you have a voice to impact the curriculum, and those that do, especially on the panel, those that do have that power, to absolutely make sure that we're doing our part by implementing and speaking up. But in the beginning, I think at this point where we are now, and I hope I'm not being pessimistic, but where we are now, I think that it's really incumbent upon you to remember that you're an adult learner, and that part of this effort has to be, the onus has to be on us to want to have something better, to want to be better, and to want to do better for all the communities and all the differences that are involved.
I echo what Dr. Rodgers said. I mean, within the field of dermatology, it was only in 2002 that the skin of color field, which is a field that focuses on skin conditions and hair conditions that disproportionately affect darker skin types, that it was only in 2002 that was even recognized as a subspecialty, if you will, within dermatology, and it's not integrated into textbooks yet. So it's going to take some time to get to that place with our books. But as a resident, I joined the Skin of Color Society. I kind of, you know, sought out my own, in addition to, not in place of, you know, my own learning on the topic, so that I could be well versed on diagnosing those conditions and the nuances of diagnosing that. I think it's kind of a unique situation within our field, because skin color is, you know, that's the whole reason we're having this panel, if you will. It's just so much comes with it, right? History and emotion. And so when you add a rash or a skin condition or a hair disorder on top of that, it becomes a whole thing, you know? So I think that we are going to see a shift eventually in how we're learning about those disorders. But until then, it is up to us to kind of have these sessions, learn from each other, and do some adult learning on our own as well.
Thank you for those comments. Another question that I have is about implicit bias training or diversity and inclusion initiatives. So have any of our panelists ever participated in such event in school or in the workplace? And what was the outcome of participating in such? Do you think it was effective? And maybe what are some sort of improvements that could be made upon implicit bias training?
You know, I will say at the macro system level, it is available. It's part of the onboarding process while you're getting onboarded into the hospital. And we do have a diversity and inclusion committee. I do sit on it, and many of the projects and that we've tried to push out and the barriers that we're coming across, and this is an opportunity, I think, across all healthcare, is that the funding priority doesn't always come to the diversity and inclusion bucket, right? We're trying to push for nicer equipment and different other projects in the hospital that system feels that is a higher priority than supporting some of the projects for diversity and inclusion. And that's a weakness within the healthcare industry, I feel like, not really supporting financially, because there's so much more that we could be doing than what we are. So that's an opportunity that I'm finding. We do have it, and we do advocate for diversity and inclusion, and especially within our hiring process. And you'll see on campus that we do hire a very diverse group of people, and we've made excellent strides in that fact. But as far as going further and supporting the staff that have ideas behind what could be done better, I think that is definitely an opportunity in all hospitals.
So I currently chair the Diversity, Equity, Inclusion Committee at the College of Nursing, and I've attended a lot of, not necessarily implicit bias trainings, like maybe they were not like labeled this way, but they were trainings to enhance diversity and inclusion on campuses. So I do have a lot to say about this topic. I will try to make it very short because I'm obviously not at all like either impressed or convinced with the way we understand diversity or the initiatives that most healthcare institutions or academic institutions think of diversity. Most of the times it's a checkbox that we need to like report that we have a committee, or we have a diversity officer, or we recruited a certain number of diverse faculty or students. But again, going back to like the support and inclusive environments that do not exist, shows what the priorities are. And going again, adding to Dr. Mendoza's point, where there are no budget allocated for any of those committees, that there are, when faculty are recruited to be diversity officers or associate deans for equity and inclusion, they're also asked to do like 500 million tasks in addition to being in that role. So it shows you like there are no like real commitment from leadership to really give individuals a full role to help uplift like the inclusivity and the diversity of the university. In addition to that, I was going to say something and I completely lost my train of thought. So yeah, I guess I'll stop here. There's a lot to be done, of course. And what I was going to say is that there's always, I feel like from my experience so far at the university, that it's always people of color who are looked for to solve the problems of the institutions in those diversity and equity committees or initiatives. So it feels like the obstacles are creating more obstacles. So when already faculty, staff, and students of color are being challenged on so many different ways because of institutional barriers, they're always asked on above and beyond what they are supposed to be doing to solve the problems that they are already facing. So it just becomes a vicious circle that doesn't really do much. And so that's where my thoughts are on how we address diversity in institutions. Again, I don't want to be pessimistic, but so far I have not seen like really good models or examples of trainings or initiatives on campuses that help with these issues. Thank you.
Thank you. So what are some areas in the healthcare industry or even academia that you believe are in need of improvement?
I don't want to be pessimistic, but I think summarizing what everyone has said, everything needs improvement. I don't know.
I didn't want to be the first one to speak up because I didn't want to be pessimistic either. but I would say I think that the reality is that the things that have created the necessity to have this conversation, right? And so I don't think that there is, as I try to pontificate on the question that you asked, to see if there was any area of medicine that was free of needing an improvement. And so I really can't tell you that there is. And I think it starts from everything from the top down, right? Or bottom up, however you want to look at that. But when, you know, you need administrators, you need physicians, you need nurses. Oh my God. Nurses are true advocates for a lot of things that get moved through in terms of processes and an improvement, just because usually physicians are, at this point, the way that they've kind of made so many cuts in terms of what physicians do and what things, you know, the leaders do, it's just very difficult to have an interest outside of just patient care. So I don't think that the job necessarily allows you, you know, really, they I shouldn't say allow it, but they don't facilitate that for you to be able to explore that avenue. So we need help in that arena, as well as residency, right? Being represented in residency, all types being represented, and trying to figure out if we're not all represented, why aren't we all represented? Then of course there's medical school, there's college, right? There's high school, there's just routine public education, right? Just for the children that are going to school, right? What do those barriers look like? You know, when you look at even the test scores, when they talk about the test scores of people that are in third grade, right? So by the time you get to third grade, depending on what your grades look like, could determine what your future looks like, right? And I hope not, because my children are in the fourth grade and I can tell you they are something else. So I'm hoping that part to not be true, but you can kind of see how, as you start to peel back this onion, that it really just, it's a lot of work to be done. And I think every avenue, every area, every level of that could utilize improvement. And I would say if there was one thing that I think is the most important thing, I would say it had to be inclusion. As I think about one of the other questions that you posed in terms of how did your medical education prepare you for this type of work? And it doesn't. The people who prepared me, unfortunately, like Dr. Abood mentioned, are my colleagues, right? So people that I just so happened to be fortunate enough with to be in residency. My residency was very diverse. And because we were very diverse and very close, I had the opportunity to be able to learn more about other cultures and things that I had never experienced, or things that just weren't, you know, accessible to me as being somebody who's from the inner city, right? So yes, inner city is diverse, but there's still a whole bunch of other people that I didn't know, like what their lives were like, what challenges they face, what barriers they face. And so it was really good to be able to train next to other people who were different than me, because we all got a chance to share our experience. So I think that my life and my medical training became much, much more rich. And I hope that, you know, I was able to reciprocate that. So that way, when I take care of patients from other cultures, right, other genders, right, other identifications, I feel a lot more comfortable, just because I had that opportunity to train with people that are similar. So they were able to kind of show me what things that I was completely missing, right, when you're learning. And then just to kind of also help me spark my interest of what things I know I need to follow up on, right? Because as physicians and as leaders, nobody ever wants to not be able to understand, like understand a patient. I think that's kind of one of those things that you never want to be that person. So because that is a drive that I have, then for me, then that's something that I have to keep pushing for. But I think that there is no area that would be free of needing to make a huge overhaul. We got a lot of work to do. And again, I'm not being pessimistic either. So that last part was trying to be optimistic. So we have a lot of work to do, and I think we can get there. There you go.
One of the other, I guess, onion layers, so to speak, Dr. Rodgers, thank you for coining that term, is looking at healthcare literacy as well. We have a lot of patients who are multilingual. English is not their first language. We have a lot of patients who are illiterate and too scared to admit it. And then we have these high patient staffing ratios where the nurse doesn't have, time to sit down one-to-one and really assess this patient's healthcare literacy. So then we send them home with an education packet of what we've expected them to learn over the course of their stay or their clinic visit, and then do some quote unquote self-studying, and then come back to the next appointment with any questions or call with any questions. Well, what happens when that person is illiterate and hasn't said, or English isn't their first language, and you haven't provided them with the right language to read into? That also poses huge implications on their care, because you're only getting half of what you put in. The patient isn't receiving what you're putting out, right? So I think that's one of the other layers that hasn't been addressed very well. Yes, we do put our work in third grade to fourth grade reading level, but there are still some huge gaps that are occurring, especially from the inpatient to outpatient side.
Thank you. So what are some steps that students can take to maybe approach and improve these conditions? And can you provide any insight in navigating the healthcare industry from the student perspective?
I would say the first place to start is getting involved in your student councils, making sure that you have a strong foundation in school, or even if you don't have something set up in school, that you're the voice that brings it up to your program directors, that you need something like this instilled. And then the second thing that I would recommend is, like I said, just being very well versed in who you put into power, whether it's in office or any office actually. If there is any change in power anywhere, and you have a say, be educated in who you are promoting or backing, in terms of how they're going to support you in your education.
I would add to that, in addition to student councils, try also going on other committees. So all committees, like for example, in the College of Nursing, we need student representatives. And so having student representatives on curriculum committees, on admissions committees, on the diversity and equity committee, helps you also start understanding the internal complexities of educational institutions, the politics that happens behind the scenes, how decisions are made, but you also would have a voice in those decisions. And be involved also in associations and organizations that are related to your professions, because a lot of those also make those decisions. Like for example, the American Academy for Colleges of Nurses, or the American Nurses Association, specifically for nursing. And similarly to other healthcare professions, you have those associations where they have impact on curriculum, on practice, on guidelines. So being part of these, just to either to vote on some of those decisions or to be in those leadership, gradually become part of those associations as well. So that helps you also navigate, moving into your practice later on, get a better sense of how the system is made up.
And also, if you have an opportunity to ask to shadow I know Dr. Rodgers mentioned earlier, like she learned from her colleagues, and I find that true to be true in my own practice. I didn't understand the politics of everything when I was a bedside nurse, but as I transitioned into my advanced practice role, politics is embedded in everything that we do at the system level within my organization. So if you have a chance to shadow, take that opportunity to shadow, because you can just learn a lot just by listening to what's happening around you.
Thank you. I just want to say thank you to all of the panelists who took the time to come and speak. So I know we're not here physically, but if everyone could give them a round of applause, that would be great. So I'm going to pass the reins on to Madeline for closing statements, and then also a Q&A between the panelists and the Zoom attendees. Thank you.
So thank you, everyone. We really appreciate everyone joining today. It was nice to see everybody, see everybody online. But we want to thank everyone for taking the time to come. And we discussed patient-centered care, advocating for patients outside of the hospital setting. And then we identified different ways that students can work to address racial bias. So now I want to open up the platform for questions from attendees. So you can put your question in the chat and I can relate this question to the panelists for you. I have a list of guidelines. If you want to check those out, I just put it in the chat. One moment. And then you can use that to address your question. So yeah, just go ahead and place it in the chat.
And also, this is directed towards the panelists. If there's any topic that we didn't address that any one of you might want to touch on, feel free to go ahead and unmute and talk about it. Thank you.
Something that just popped into my mind as far as getting involved. I know many of you will need to do a dissertation of some sorts. So this topic and all of its components, if you were even to tackle one of them and work with somebody in the research department to put out a piece of literature, not only helps your professional development, but also spreads the word about the deficits that are happening within the healthcare industry and exposes the needs that are still occurring that may not be seen as a priority. But your voice counts, and that's one of the ways that you can get your voice out there in professional literature.
Something else that just popped in my head, jumping off of what Dr. Rodgers said about her experience in training and just finding colleagues that you can lean on. I guess also jumping off of what Dr. Montesa said, that we've been focusing on diversity. We're trying to push towards inclusion, but the next step of that is belonging, which you guys know, and making a space that a person of color is going to be able to, succeed in. And so until we get there, I think it's really important, if you're navigating medicine, to create that space for yourself, if you will. Like I was like, I'm going to have 3 mentors in this field that I want to go into. I'm going to network with this person and maybe they could be a sponsor. I'm going to create study groups. I'm going to just be as active as I can, because no one is going to care more about your success than you. So you really, really, until we get to a space where we have that kind of support, we need to work really hard to create that for ourselves. And unfortunately.
You know, I completely agree with that too. I think that I would probably add one more thing. I think that and this is for all of us, and this is something that I had to become more comfortable doing probably within the last 6 or 7 years of just my own training, and that is just you know, just kind of finding your voice. And so I say that as to say that, you know, when you don't feel comfortable, like, you know, when you're in a space and somebody says something or somebody does something and it's uncomfortable, whether it's to you or not to you. I think just to kind of have the power to just say, you know what, I'm not comfortable with that, and leave that space, or, you know, be comfortable enough to challenge it, to say, you know what, why do you said this? I'm not sure I understand. It made me feel uncomfortable, and I'm trying to understand why. And I think sometimes just kind of posing that challenge to other people kind of forces them in certain spaces where everybody may not be represented to kind of take accountability of what it is that they're saying, and then to know that, wait a minute, that's not okay. Like, it's not okay with me, right? Because I think part of this, you know, in terms of where we've gotten, is a lot of it is just being complicit, right? So like, you being present and you know things don't feel right, but you just, okay, I don't want to be a part of it. I just won't say anything. But not saying something sometimes is just as bad as you being the person who's actually doing it. So just trying to getting used to kind of finding that voice to say, you know, that kind of made me uncomfortable, or when you refer to me as this, like, you know, I don't want to be referred to as he. I'd rather be referred to as this, or you should have asked me what I wanted to be referred to as. So I think just having that, being able to kind of just, again, have that strength, just to simply say it in a professional way. But I think it also allows the space for other people around you to feel comfortable knowing that, wait a minute, that person spoke up, maybe I should have too, or, you know, that didn't make me feel comfortable either. So you would be really surprised that a lot of the shared experiences that we have, that we don't utilize our power in, because we're allowing ourselves to stay isolated, right? Maybe it was just me who felt that way, it might not have been just you. And so just kind of, you know, again, just finding your voice and finding your temperature of what you feel comfortable doing, whether it's saying, okay, I don't feel comfortable saying something in that moment, so I'm going to send an email. But I will exert my voice, because I do want to make sure that I make this space safe, not just for me, because I think that what we're saying is that it's going to take us all, right, to do it. I won't be able to exist in every space to advocate for every minority, right? But you may. And so if you have that opportunity just to say, like, you know, I don't believe that, or that doesn't sound, that's very uncomfortable, or I can see how, like, I think that this practice is, do you think that this is excluding, or is this creating a barrier? Again, just to kind of make other people take a step back and think about what it is that they're doing and holding themselves accountable, I think is very powerful as well. A small step, but very, very powerful.
Thank you, Dr. Rodgers. And Yvonne posed a question to, I'm assuming this is for all of the panelists. And she said, as someone who's not in the medical field and being a patient on many occasions, how do you show up for yourself when you feel that you're not being heard by medical professionals?
I think it goes back to that patient-centered care, bringing that up to your provider, that these are not the things that I have in my plan of care for myself, or these are things that are not feasible for my lifestyle. Those are some key phrases that you can use with your providers. Or like, these are resources that I need in order to be set up for success when I'm going home or when I'm at home. Those are just some tips that I would use.
I do think that it's also important to remember that it is a relationship, and hopefully it's a you know, a longitudinal, a long-term relationship. And again, kind of what we talked about with the patient-centered care, that this is your health, and you should feel empowered to bring up the potential issues that you might have, you know, meeting that care plan, or if that care plan doesn't fit for you. And I do have patients, I mean, especially within my specialty, who have to search for a while until they find a comfortable fit. And I'm not personally offended, and I don't think anyone in our field is offended if you know, don't feel comfortable and you want to search for that comfortable fit, because we are going to be working closely for a long time, and it needs to be the right fit too.
I completely echo that sentiment and everything that Dr. Robinson and Montessa have said in terms of trying to advocate. I think that I agree. It's a relationship. It's a two-way relationship. And so I just kind of giggle a little bit because I've had it both ways, where there may, you know, we have patients sometimes, especially in OB, right? This is that, again, it's a very unique part of medicine where, you know, if you've had a baby, or you know somebody who's had a baby, or if you've been a baby, you're an automatic expert. So it does become very challenging sometimes as people come with, you know, things that either they want or barriers that they may have. And so the barrier part is a little bit easier because that, you know, it's sometimes it's easier to deal with, but sometimes it's not. Sometimes my patients are coming and they're in very misogynistic relationships where you ask the patient something and the significant other like completely takes over, and not in a cultural sense, but just takes over, where you can kind of see like, okay, wait a minute, there's a lot going on. So sometimes there are, in building that relationship and trying to garner that trust quickly, because again, we have just a snapshot of time, trying to garner that really quickly. Sometimes you do identify that, you know, actually maybe this is not the best fit. Like I may not be the best provider to do the best for this particular patient, just because I may not have the skills to be able to deal with the social part of what it is that they're asking me. So sometimes that comes up. The other thing that may sometimes come up is that although patient-centered care is great, you still have to make sure that you're following the optimal and standards of care, right? So every now and then when patients may have expectations or things they can or cannot do, it may completely be different than what you know will be best in terms of optimizing. So I like to just kind of have those conversations, like we have the ability, and not everybody has that ability because of the business of your practice, but we do have that ability where we will kind of have what we call our group meeting, meaning that we all come to the table and let's kind of lay it out and say, okay, this is what we know works, or these are the goals. What is it that out of these goals, how can we agree on something that will be, you know, in the middle for both of us? So something that won't harm, but at the same time that gives you as much autonomy, leeway, and goes against barriers as possible. Can we find that line? You know, of course, we all understand that no one patient follows the exact book, right? They're not going to do exactly what's in the book. There's real life that happens, as I always tell my patients, right? There's my recommendations, and then there's life. And so we have to figure out like how we can make those two meet in the middle. So if it's something that is just very, very divergent, then, you know, I think we always have that conversation of whether or not we're the right people. We want you to get the best care. How can we help that? If we can't facilitate that, then it's incumbent upon me to try to find somebody to help you do that. And we're more than happy to do that. And there's no pride in it. Right? I will be some people's cup of tea, some people I will not. And I think you have to go into it being okay with that, because I don't want to center their care around me. It's about them. So if I don't think that I can help, then let me try to find you somebody who we think can help you, because that's really the ultimate goal. So I think when you kind of go into it, from that aspect of understanding that it is a two-way relationship. If you're not getting what it is that you need or what you feel like you need, or you're not feeling like you're being heard, I think it's fair just to say, hey, doc, wait a second. Let me explain it to you. Let me make sure that I understand it as to why you think it's important for me to do that. And if there is no ability to kind of have that conversation, or you're not comfortable having that conversation, then I think that maybe the question may be like, can I ask to see somebody else that's in your same group, right? Or, what else is it that I can do to, make sure that I'm prepared for my visit? What things should I expect from you, right? So if you're giving me the exact same thing that you give everybody else, then maybe it's just not the practice for me. But I just want to be sure that you're not giving me less than what you would give somebody else, right? And so I think just kind of exploring that relationship is really key. It's really key. I'd also say that I think it's good to sometimes lean on your social support, right? So if you have one, I can't speak to what everybody's have, but if you have a social support, to ask around, to say, hey, this is the problem I'm having. What do you think I should be experiencing? So what do you think should be happening? So just so you kind of have some idea of what you think that reality should be like when you actually show up as the patient, and now you're required to kind of advocate for yourself. So I think that, being really astute it's important, right? It's something we can't leave. I don't want anybody to leave their healthcare just solely up to me. I want you to be, to participate in it. Because when we make a decision, when you leave my office, it is a decision that we have made together. So whatever outcome we get, it's because that's what we decided to do as a group, and not what I'm just telling you to do. So those relationships are so important. So maybe that person may have to try to seek that out, in a different arena, or with a different provider, depending on what it is that they need. It's a little bit harder for subspecialty care just because the subspecialists are so limited, but nonetheless not impossible.
Thank you, Dr. Rodgers, and thank you, Yvonne, for that question. We have a question from Sana, and this is for Tracy. And she says that she's a pre-nursing student, and she wants to know how your journey was as an undergraduate, and then what you would recommend for opportunities in nursing.
Hey, Sana. Well, congratulations, first of all, in choosing nursing. My journey as an undergraduate student, I did at Loyola University, and then I went to Rush for grad school to get my APRN degree. So I definitely love the nursing journey. You get a lot of experience at the bedside once you've graduated your undergrad, and I think that really gives you a larger perspective on how to approach patient care when you turn into your advanced practice role. So there are 4 levels of advanced practice once you've gotten some clinical experience and you're ready to go back to school for your graduate level. There's a certified nurse practitioner, certified nurse anesthetist, certified nurse midwife, and then certified clinical nurse specialist, which that is my degree, and I work here at Advocate Illinois Masonic now for over the past year. So nursing has a lot of different avenues that you can take, as you can imagine, but I really think that the experience that I received from the bedside made me a better provider. So I really attribute that to all of my nursing experience in telemed-surg, and then also I did 8 years in the ICU over at Rush.
I'd like to pose a question to all of our panelists. Maybe you can speak on your experience, maybe working in private practice versus institutions like a hospital, and how they may differ in addressing patient-centered care and like institutional racism.
Temi, these are heavy questions. I have worked in both the hospital setting. I've worked in academia. I've worked, and now I'm in private practice. I would just say they're just very different practice settings. In within dermatology, there is the outpatient setting, there's academic medicine, there's private equity, which has its own culture, and then there's these small practice groups. My personality type, what I wanted for my career, I think fits better in a private practice group. I think you have a little more autonomy, and that extends to everything. That extends to, you know, how you customize your version of patient care, or what patient-centered care means to you. I can really like tailor that a little bit more in my private practice. But I think that, you know, when you're with an institution or with a hospital, you have more resources, and maybe you could potentially have a wider reach, you know, depending on that. You might be part of a larger department. So I think there's benefits to both scenarios, and we need advocates for diversity and inclusion in all areas. But I do think, you know, when it comes time, I know everyone's at different stages that's listening in here, but when it comes time to making that decision of what practice setting you want to go into, just considering those factors and what you want and for your career is important.
Yep, I agree. I am a little bit different practice model. So I'm in a hospital-based practice. And so I would say, in terms of combating institutional racism, yeah, I agree, it's kind of heavy. I don't necessarily know that there's a direct kind of combat group, I guess, so to speak, from our hospital standpoint. A lot of it is driven just usually based on the administration. The other way that is driven for us is that we tend to mirror academia, the world of academia. So if there is something that's going on in academics, then it'll kind of trickle to us, but we're usually not the forerunners of that. So we really do use our academic institutions that are within our vicinity to kind of, you know, take that lead. So and national organizations, I would say also. So once it became something that was way more prominent and acceptable to kind of have these conversations with, you know, statements coming out from different organizations, like for us, the American College of Obstetricians and Gynecology, Society of Maternal Fetal Medicine, when they became more vocal about what we should be doing, it made it a lot easier to kind of make that transition and have expectations for our administrators at our hospital. I would say, though, the majority of it is driven by admin. And so unfortunately, with hospital-based practices, the admin is, you know, their focus is just different. The focus is different. So they are running a hospital. So they're trying to, so to speak, in a nutshell, I don't want to minimize their jobs. However, they're running a hospital. It's a business. It's a hospital setting business. And so that's what the predominant focus on in terms of, you know, driving the continued conversation about diversity and inclusion. Is really incumbent upon the physicians, the nurses, the students, and everybody else who works there to kind of push the envelope in terms of making sure that we have that conversation. And then I think the last body that kind of looks at it, I don't necessarily know that they do anything, which I think is a huge problem. Like we can talk a lot, but I think, and the talk part is very heavy, but when you look at the action, it's not as heavy. It's not balanced at all. But one of those places where they at least look at it, they will ask you about it, is when you, if you ever heard of a hospital becoming magnet status, then that's one of the things that they try to look at to see, you know, whether or not there is representation at your hospital on each level. But again, I don't necessarily know that if they know that that isn't achieved, that they do anything. There's no action that's necessarily behind it, but they will call it out. But yeah, so that's kind of the hospital-based model. We're kind of right in the middle, I'd say, probably right in between like private practice and academics. But again, we try to mirror the temperature of what goes on in academia. We're just usually a little bit behind that, but that's typically the temperature that it takes. So if academia is making a strong stance on diversity and inclusion, eventually it'll trickle down to us to implement that in some way.
I also work obviously in a hospital setting, and we do have magnet status. So Dr. Rodgers is exactly right. There are categories that need to be addressed in order to fill that magnet status, and one of those is diversity and inclusion. So we do address that in our hiring phases and also in our diversity and inclusion committees. So there are multiple avenues that we're trying to address the situation. Institutional racism is large. Obviously, that's not going to be just won over by a committee or task force that is looking at it. They might point out some key tips here and there, maybe have a speaker on nursing grand rounds or education that rolls out, or training during their orientation process, but it's much larger and it takes a lot more time than that to combat institutional racism, as we very well know. So we have a standard of practice here at Masonic, and a lot of it comes from our leadership and their expectations of how we treat each other and how we hold each other to those expectations. So I feel like the culture here within my organization has upheld those values at least, and that's a great start. But as far as having heavy-hitting conversations that run deeper than that, there's always work to do.
Wonderful. Well, thank you guys so much again for speaking today. It was nice to have everyone here. I'm going to give the floor to Faria, and she's going to talk about some of our upcoming events that we have.
Hi, everyone. I just want to thank you all again for joining, and our panelists for speaking and providing amazing insight and taking the time out of their schedule to be here with us. Some upcoming events for WHI and upcoming events related to the topics that we discussed today. I just wanted to share a few of those. On October 1st, the UIC Department of Medicine Inclusion Council will be having a seminar discussing the racial caste system and its impact on patient outcomes. The 27th of October, WHI is holding a workshop in collaboration with Nicole Banwell, a registered nurse, on contraception options. And the week of November 9th to the 15th, it's going to be a week-long campaign in collaboration with the Minority Association of Pre-Med Students at UIC, talking about discrimination in academia. And our other event in November, the date is to be determined, but we're going to be discussing lateral violence in healthcare, a seminar in collaboration with the Student Nursing Association. And I have provided links for the first two events that I mentioned in the chat. So if you're interested in those, any of those events that I mentioned, definitely check those links out. But other than that, thank you again for your time and have a nice day.
Thank you. Thank you for inviting me to participate. And hopefully I'll see some people interested in OB. So hopefully I wasn't too pessimistic. I think it's still a great field. We have a lot of fun, maybe not as much as Dr. Robinson in dermatology, but definitely, I mean, if there's anybody who is considering or needs more information regarding obstetrics and gynecology, I'm always up for the task to kind of discuss that in terms of what we do and our field and the direction of our field. So please reach out, and you can I should have a UIC email, but I don't know if I check it, but I think that Madeline probably has my information, so feel free to share it. Thank you, guys.
Yep, thank you guys for having us, and Madeline has my information as well if you want to reach out for any tips in the nursing field or advanced practice nursing field.
Yep, thank you guys. This was really fun, and you can reach out to me anytime if you want to learn more about dermatology or general questions. Temi or Madeline has my information.
All right, thanks everyone. Well, on that note, I'm going to close the meeting once again. Thank you for joining. It was nice to have you today. Bye.
Thank you.